medical appointments. And at that appointment, the physician can review the coping strategies, the progress or problems that have developed. They can answer questions, give insight into possibly some new treatments that are becoming available, and also they can probe the caregiver's feelings. The caregiver often has feelings of ambivalence, sometimes guilt feelings, like when the Alzheimer's patient is extremely debilitated, they may even wish that the patient had died, and this, of course, brings on guilt. But it's a very common occurrence that when somebody is so ill, and we've seen several cases in Florida, like where the Gilbert case, where the husband killed his wife because she had Alzheimer's disease, and he didn't want her to suffer. So there is this idea of wishing that the patient would die and get the suffering over with, and also probably to preserve the caregiver's life as well. Do we have any, we've gone through these 10 items. Do we have any, are there any questions about any of these things that I mentioned? Okay, I would like to then turn for the last part to some of the aspects of Alzheimer's disease and how they produce stress in the caregiver. And for here, you can refer to this table in the handout, which we've already discussed the bottom. You can look at table 1 and table 2. Memory loss. Memory disturbance is listed as number 1. And as we mentioned before, the patient does appear to understand, but his mind is like what we call a cognitive sieve. In other words, he seems to understand it, but he's unable, or she is unable to get it into memory, short-term memory. The long-term memory is reasonably well preserved, and the caregiver should try to enhance the long-term memory by talking about many of the things in the past, so-called reminiscence, because these are well preserved, and they tend to help preserve the relationship between the caregiver and the patient. Another thing that can help in the memory loss stress aspect is to provide an orientation center in the home, and where you have like a bulletin board where you have, we'll say, pictures of the relevant people, friends, relatives, and also in the home you can have like signs and labels which help facilitate the memory. The maximum stress for the caregiver is said to be when the patient no longer recognizes the caregiver. And this is often a time when the caregiver is the last straw that leads to institutionalization. But it should be emphasized too that this can be something that comes and goes. It may be present one day and gone the next. I think you've experienced that, haven't you? Okay, disorientation on the part of the patient produces a lot of stress, and this can often be minimized by the environment. We know that any change in environment will aggravate the cognitive impairment, such as taking a patient on a vacation, or taking them to some new location, or changing their room even. Sometimes moving an Alzheimer's patient from, we'll say, the upstairs to downstairs, it makes for a great change in their cognitive function. It said that for the caregiver, when they want to relieve some of the stress, they want to take a vacation, they shouldn't definitely not take the patient because as soon as you take them out of their environment, the behavior will change and ruin the vacation essentially.
Yeah, but how does the patient handle when the caregiver's not there?
Well, that's where you need to have assistance from the family, the community. Sometimes placing the patient in a nursing home for a week or a weekend, but not to take the Alzheimer patient away from the environment is a general rule. Is that answer?
Are you saying that's usually suggested that you not take?
Yeah, right. Because the tendency is to say, well, let's do like we used to go to the we'll say to the West Coast, and we'll spend a few days away from home, and everything will be fine. And then if you take the Alzheimer patient away, and they totally act out, and they're unmanageable. And essentially, you've ruined your few days away. So that's a general rule. I don't think you can say with 100%, but that seems to be what the prevailing recommendation is. For the caregiver to get away, needs to get away from the patient.
Put the patient in the institution and a nursing home, wouldn't that further disorientate the patient?
Well, it may, but we're talking about relieving the stress of the caregiver. I mean, the caregiver just cannot be present 100% of the time. I mean, always on call. I mean, nobody can be on call 100% of the time.
Would it not be better then if they can keep them in the home situation?
Yes, if you had somebody, that's where you need to have your family available, your friends, or some volunteers, or somebody, church, to home health. They have to pay for it though, so yes. Of course, it'd be better to keep them at home with somebody, but the caregiver has to be able to get some break. Okay, the personality changes that occur, and sometimes this we call disinhibition, in which we'll say you have a husband and wife that have always had certain problems and conflicts, but over the years they've learned to sort of manage with them. But as somebody develops, one of the members develops Alzheimer's disease, they're no longer can be covered over, and they surface, and it creates a great aggravation in the relationship and a strain. And sometimes there may be some sexual manifestations, sexual demands, which can further aggravate the behavior. For the caregiver to handle this is sometimes quite difficult, but the one principle that is emphasized is distraction, and try to and use the long-term memory, try to reminisce about things, or with distraction like let's rub your back a little, have a cup of tea, go for a walk. And the Alzheimer patient is very susceptible to distraction, so sometimes this behavior problem can be ameliorated. The next thing is diminished daily living skills. And we've already talked about this, such as dressing, driving, eating. With eating, we should try to minimize the choices of food, try to modify the types of food to make it easier to eat. We have special implements that can be used, and where the meals should be, not disruptive. We should try to keep the Alzheimer patient at the table, the family table, so that they can interact with the family, not be isolated. The next thing is diminished mobility. This is where the Alzheimer patient tends to become less and less active. It's important to encourage physical activities such as walking. Physical therapists can be helpful. The Alzheimer patient also has problems with peripheral vision. and proper lighting has to be employed in the home. And last is impaired communication. And here we already mentioned that the caregiver has to be like the word finder. It said that with difficulties with communication, the Alzheimer patient develops a great deal of frustration and anger, and this can cause them to act out and become violent. And with communication, we have to always remember that they comprehend affection and feelings and joy until very late, even though they can't necessarily express themselves. Alcoholism is also can be a hidden problem, which can produce a great deal of stress. And early in Alzheimer's disease, with depression, patients can turn to drinking, and often the spouse and family are reluctant to admit to the physician or anybody else that alcohol is a problem in the home. Insomnia is a very major stress factor for the caregiver, and it's known that the Alzheimer patient, their sleep physiology changes. They loss of what they call REM sleep, that's rapid eye motion sleep, and also their stage 3 and stage 4 sleep, which is a deep sleep, becomes less and less, so that they tend to sleep less. They awaken frequently during the night, and they're wakeful, and they tend to wonder a lot. And this causes, of course, a great deal of stress for the family and the caregiver, and often sometimes the thing that will lead to institutionalization. The physician can help by prescribing sometimes sleeping pills, which we use ones that don't have a long half-life, so that they don't aggravate the confusion. One of the major factors in the chart here, catastrophic reactions. And this is where the patient becomes very aggressive, they act out, they can hit, they can throw things, and this usually tends to occur when they develop major frustration and anxiety. And here the caregiver should try to remain calm, tend to use distraction, change the subject, and sometimes medical treatment is needed, like a major tranquilizer. But once again, this type of reaction can occur for just a few days, and then it's gone, and the treatment doesn't necessarily have to be continuous. Another area of stress for the caregiver is demanding and repetitive behavior. Sometimes there can be a phenomenon called shadowing, where the patient follows the caregiver around no matter where the caregiver goes. This can be extremely stressful, and they'll often tend to repeat themselves, same question, the same statement, the same action. And the best way to handle this for the caregiver would be to, once again, use distraction and reminiscence. Sometimes delusions and hallucinations occur. These are often not major problems. They are usually not threatening. Delusions sometimes take the form of being paranoid, and this can be ameliorated by just talking calmly to the patient, involving the patient in family affairs, so they don't get the feeling that you're just talking about them, but you're talking to them. And the professional too, the physician, has to remember when the patient is in the office, the physician should treat the patient, talk to the patient, not just talk to the family and assume that the patient really has no feelings. Incontinence is also a stress factor for the caregiver. This fortunately tends to occur late in the course of the illness, If it does occur earlier or at any time, the physician should look for causes for this, maybe infection. Sometimes there's inaccessibility of the Alzheimer patient to get to bathroom facilities, and sometimes drugs can cause incontinence. Do we have any questions on these matters that I just discussed? Okay, I'm going to turn over
What
Yes.
happens to an Alzheimer's patient who has no caregiver, who has no funds to go into an institution, who
well,
has nobody to,
well, they would probably wind up in some type of a county facility. I would
they wind up in
imagine.
Florida State Hospital?
Yeah, probably. Does anybody else have an answer for that?
They want the community to get along as best they can.
I work for the HRS, and it's up to neighbors and people noticing things. We get calls from banks that people are taking things out, you know, because they forget that they've been in there, and they'll take 10 times a day, they'll go into the bank, and they misplace the money. What happens is either a neighbor will call, or the police will call the HRS, an assessment will be made, and placements will try to be made. Mind you, we get elderly from all over the country. We have the highest per capita, I believe, in the country. It's very hard for the HRS to place them, and if they have no funds, they must be subsidized by Medicaid or Medicare in some sense. But it's up to neighbors and friends. When people have nobody, then it can go on until almost the very end. I mean, people are found in their own homes because they haven't eaten. They just get weaker and weaker. You know, it's got to be public.
My name is Mark Strand. I'm director of the Center for Gerontology, and this segment of the program is supposed to be handled by our director of social services, a social worker, and unfortunately she was called out, so I'm not going to talk on social services because I don't know anything about them and I'm not qualified to talk. What I would like to do is cover a couple of aspects of my research in Alzheimer's as to the causes of it and just potential treatment.